Hello, everyone, and welcome to Heads Up, the weekly webcast and podcast of the National Headache Foundation. I'm Dr. Lindsay Weitzel, founder of the Facebook group Migraine Nation and chronic daily migraine survivor. I'm excited to tell you that I'm here this week with Dr. Vincent Martin. Dr. Martin is the director of the Headache and Facial Pain Center at the University of Cincinnati, and he is also the president of the National Headache Foundation. Hi, Dr. Martin. Thank you for being here.
Hi, Lindsay. It's a pleasure to be here myself.
So today we have a new data update like we so often have. This one's very exciting. It has to do with medication overuse headache. It's a new trial. Dr. Martin happens to be an author on this trial and on this new study that was recently published in Neurology. This study was called the Medication Overuse Treatment Strategy Trial, or MOTS trial. So as patients, it may be difficult for us to know if we have crossed the line to where our acute medicines could be making us feel worse instead of better. If we've crossed this line, how do we fix this problem? It can seem really scary to decrease or stop taking a medicine that was making us feel better. So this is a conundrum that we have, and this is what the MOTS trial was designed to help us figure out how to treat, or a problem that it was trying to attack at least. And Dr. Martin is here to answer all of our questions about this trial and what it found out for us. So Dr. Martin, can you begin by telling us the definition of medication overuse and medication overuse headache?
Well, lay people call this rebound headache. So I think that's an important term to mention to the audience. And it's officially defined as someone that has more than 15 days per month with headache. And then they're overusing acute medications. So acute medications are just used to treat headache when it comes on. This is as opposed to a preventive med, which are taken daily or in some cases a monthly shot to try to decrease the frequency over some longer period of time. But the thresholds vary by which medication you're referring to.
Right.
So for example, triptans, which are things like sumatriptan, the trade name for that would be Imitrex, or rizatriptan, Maxalt, and there's 7 triptans. The threshold for overuse would be 10 days for that.
Okay.
Narcotic medications, things like oxycodone or hydrocodone or morphine, would also be 10 days per month. Okay. And then what we call combination analgesics, things like combinations of acetaminophen, aspirin, and caffeine, which the trade name for that is Excedrin, would also be 10 days per month. And even butalbital-containing medications, which also usually have caffeine and or aspirin and or Tylenol or acetaminophen, have a threshold of 10. Now, the simple analgesics, things like acetaminophen just by itself or ibuprofen by itself, have a threshold of 15 days per month as indicating overuse. And the theory is that if you overuse these meds, that you change the pain pathways up in the brain that facilitate pain. So it makes headache more likely to occur.
Okay, so you said acetaminophen or Tylenol, ibuprofen or Advil, those are more like 15 days per month, whereas a lot of these other things like triptans, butalbital, some of these narcotics that you named, those are 10 days per month, is considered medication overuse. So medication overuse can be controversial in the migraine community because on the one hand, we seem to be instructed to take our acute medicines as soon as we feel our migraine coming on. And then on the other hand, we often can be made to feel like our chronic migraine is sort of our fault because we took too many medicines. So a lot of us feel like we're sort of backed into a corner when it comes to medication overuse headache. So what do you say to your patients about this subject?
Well, what I tell them is first that the most important thing to do is choose the right preventive medication, even more so than withdrawing the medication. And we'll talk about what the results of the study are in a minute. But I do think that a gradual withdrawal of the overused med, and sometimes it's not always removing the med, but reducing the frequency of use down to those parameters that we just talked about, is probably in the best interest. Whether that makes a huge difference in the headaches or not Many headache doctors think it's best to get people down on the meds for several reasons. One, the overused acute med can have side effects, like, for example, anti-inflammatories. Mm-hmm. If you overuse those are like ibuprofen, naproxen, and so forth, over long periods of time, mm-hmm. that can cause kidney disease. Right. It also can sometimes ulcerate the stomach, mm-hmm. As well. And narcotic medications have a lot of different side effects too. They can affect your endocrine systems, and right. In men they can reduce testosterone levels, and there's just so many different side effects of that as well. So the goal would be, is if possible, to at a minimum reduce the frequency of the meds, and in some instances you might want to get off the med altogether. Many headache doctors think that some overused meds are much more likely to promote medication overuse or rebound headaches than others. And the two main culprits that headache doctors will list as being worse for that would be butalbital containing meds like Furanol or Furoset, right, and narcotic medications. We think that those have a higher likelihood of increasing the frequency of headaches than some of these other meds like ibuprofen or acetaminophen.
Now, that's the second time you've mentioned butalbital. Perhaps we should tell the audience what butalbital is. Which kind of medicine is that?
Well, it's a barbiturate, okay. But it also has trade names, like we said before. Either Furanol or Furoset are the most common trade names for the med, and they're combination medications. Like Furoset mm-hmm. has acetaminophen, caffeine, and butalbital. Okay. And Furanol has aspirin, caffeine, and butalbital.
Okay. All right. So historically, in the setting of medication overuse headache, patients are often asked to completely stop taking acute medications for a certain period of time. Is that correct? That's sort of one of the historical approaches to medication overuse, correct?
Absolutely.
And so in contrast to this philosophy, I believe, what was the goal of the MOTS trial? How was it conducted?
Well, the trial was conducted, they wanted to explore two different treatment strategies for medication overuse. Mm-hmm. So basically, one strategy was to put a person on a preventive med and then to take them off the overused med and to switch to a med in a different class, but they wouldn't use it more than a couple of days a week. So you'd switch to another med and it wouldn't be overused, but it was an abrupt withdrawal. Mm-hmm. And then the other strategy was put people on a preventive med. So mm-hmm. both groups got preventives.
Okay.
But they can overuse the med. They can take the med exactly like they're taking it. So if you're using it 15 days a month or 20 days a month or whatever, you can continue doing that. And then what they looked at was the frequency of headaches at 8 to 12 weeks after this intervention to see whether there was any difference in the two different strategies. So it really looks at two different common treatment paths for the treatment of medication overuse headaches.
Okay, so basically everyone got a preventive that was best for them, but some people were removed from their acute medicine and given a different one and did not overuse, and the other people just kept using the acute medication in the manner in which they had been using it.
Exactly.
Okay. So what happened? What were the results of this trial? What did we learn from this?
I think it was kind of interesting. I think that if you'd asked most headache physicians what they would have anticipated would have happened is not what the results actually were. Mm-hmm. What we found is that there really was little difference in the two different strategies. The headache frequency was pretty comparable at 8 to 12 weeks, no matter which strategy that you employed. So what that really means is that the most important thing when you're treating someone that has medication overuse is probably not the withdrawal of medication, but is putting them on the right preventive. Both groups had an improvement in headache frequency at 8 to 12 weeks. So, and that's kind of groundbreaking in a sense, because if you think about it, this whole concept of medication overuse has become very divisive in patient care, because there's not a greater negative aspect of a patient visit. But if you start to blame the patient for their disease, well, by God, if you just stopped this overused med, then your headaches would get better. Well, what this suggests is that to the doctor is, hey, if you get the preventive medication right, then that'll probably make a bigger impact than getting them to abruptly stop their med and not overuse their acute medication. So I think it takes the blame off the patients to some degree. Now, with that said, as I said before, many headache doctors still would like to get, even if that were the case, the frequency of overused meds down. But I would contend that oftentimes that would happen anyway if you got the preventive medication right.
Right. So I wanted to ask a couple of questions for our audience out there in case people are wondering if this would work for them or if this applies to them. These patients in the trial, were most of them, did they have chronic migraine? Did some of them have episodic? What type of patients were they?
No, these are people with chronic migraine.
So they were chronic. So I think that's important for everyone to know. There was sort of a secondary accidental finding to this trial that I found super interesting myself that I wanted to ask about. Does it seem that it's possible that a person's level of anxiety could possibly play a role in their recovery from medication overuse headache?
Well, in this study, what we looked at were a subgroup of people that had moderate to severe anxiety. And in that group of people that were randomized to the group that abruptly withdrew their overused med and also still maintained a preventative, that group of people actually did worse in that strategy. And the thought was, maybe if you're really anxious and you go off of your overused med, which you've depended on for so long, that it might actually increase your anxiety, and that may somehow make your headaches worse. But that's just a theory, and was just a subgroup of patients that were looked at. So I would not in any way, shape, or form call that a definitive result, because that was not the primary purpose of the study, but it was an interesting observation. And then another subgroup that was interesting, and kind of an aside, now that you're mentioning subgroups that may have responded differently, was the group that had really frequent headaches, like 25 to 30 days, did better in the subgroup that had abrupt medication withdrawal along with their preventive and then switching to another med. So there could be subgroups of people that may do worse or may do better depending on frequency of headache or by anxiety.
Okay. I'm going to ask you another question that was just sort of something I thought of as I was reading the study. And then I'm going to ask you to sort of deliver what you think is the main message of the MOTS trial. So I personally believe that one of the things that sort of scares patients when a doctor starts talking to them about medication overuse, I feel like there's a belief out there when we go into a doctor that talks to us about this, that with a person with chronic migraine in the setting of medication overuse, it's sort of presented to us as our entire problem is medication overuse, and we will be entirely better if we just stopped taking this acute medicine. And it often just comes across this way. Is that what happened in this trial? Is that the truth? Is it the entire problem often when someone has chronic migraine that it is because of their overuse of medications?
No, that's categorically not. Only about 50 or 60% of people in a headache clinic population with chronic migraine actually have medication overuse. So there's still people that develop chronic migraine even without a medication overuse. And I think what the trial says is that it's not your fault, is that the most important factor is getting on the right preventive. And now there are 3 other studies besides the MOTS study that have shown that if you get on the right preventive, that the frequency of migraine will reduce even if the medication overuse continues. So there was one trial with onabotulinum toxin A, there's another with topiramate, and there's another one with arenumab, which is one of the monoclonal antibodies. So, this is just adding to the evidence that the most important factor is get the preventive medication right. And when you start dealing with chronic migraine patients, it's not just about putting them on one preventive. The odds and probability that one preventive is going to work in a person with 20 or more days per month with headache is not very high. Oftentimes you need to combine multiple preventatives. But if you do that, the headaches will reduce and the frequency of medication use will also decrease as well.
Right. So what would you like to add to our discussion of the MOTS trial? What is the take-home message here?
Take-home message is don't blame yourself.
That's a great take-home message.
It's not your fault. Not to say that there couldn't be some contribution of medication overuse to frequency, but it's probably not the primary player. The primary player is probably your biology and other factors in your life that might have caused your headaches to ramp up from episodic into a chronic pattern with medication overuse.
Okay, great message. Thank you for being here with us today, Dr. Martin, to discuss the MOTS trial. And thank you everyone for joining us on this week's episode of Heads Up. Please join us again next week.